introduction and invitation to present some of our work today. These are my disclosures, some consulting fees and research support. So I don't think it's difficult to get everyone across the finish line here that cancer care is increasingly complex, right? So we have greater understanding of the molecular genetic background of cancers. We have greater recognition that breast cancer is not 3 things, but many more. We actually recognize more than 100 different blood cancers currently in the WHO, 2016. And this has not only led to increased diagnostic complexity, but greater understanding of the disease has led to new treatments. So there's been about 50 new cancer therapies approved in the last 5 years. And most of these new therapies are novel, either small molecule inhibitors or immunotherapies. They really have administration as well as side effect profiles that are dissimilar from our traditional cytotoxic chemotherapy. It really was the mainstay of medical oncology for decades. Combine that with an aging population, and we really have a greater complexity in delivering modern cancer care. And so what do we know about delivering complex cancer care? In fact, if we look at the surgical literature, we understand that the clinical volume is actually important, both at the surgical surgeon provider volume as well as hospital. If you look at GI malignancies or lung cancer malignancies, you'll see similar analyses done, which show that as the experience of a surgeon goes up, hospital experience goes up, typically outcomes are better. So this is esophagectomy. The next 5 slides will be focusing on this level of surgery, which is quite complex, in hospital mortality rate being about 5 to 10%. And there's been a number of observational research studies that have shown both provider and hospital level volumes associated with outcomes. This is the meta-analysis. The takeaway, if you are having esophagectomy at a low volume hospital, 8.5% mortality in 30 days compared to 2.8% in high volume hospitals. So recognizing this association has led different nations to different policies. So in the UK, they started seeing this data, and they basically centralized esophagectomy starting in 2001. We don't have that level of centralization in the United States, but we do have these volume-based selective purchasing. And so effectively, there's patient safety organizations that look at volume of the hospitals, look at the quality metrics, and they guide insurances to contract with higher volume, higher quality hospitals. So what's the policy outcome here? So in the UK, if we look back in the last decade, the provider volume of esophagectomy, so surgeons doing esophagectomies, their average case number is 20 per year. In the US, that's 4.9. There certainly are large volume providers here, but there's a lot of care being driven by the lower volume hospitals. And at the end of the day, the hospital mortality rate for a esophagectomy in the US is actually inferior to the UK. And on multivariable analyses, the volume is a major driver. So it's generally accepted that clinical volume is associated with outcomes following complex surgeries. The mechanism is likely multifactorial. Certainly surgical skill is important, proficiency, but also processes of care, hospitalization, and organization, having specialized units, having the appropriate nursing to staff ratio. While we know surgical importance of clinical volume and outcomes, there really has been understudied of the non-surgical location of, volume outcome association for complex non-surgical care is really uncertain. It just has not been studied. And so where is cancer care, medical oncology delivered in the United States? It's primarily in the community setting. So about 80% of care is in the community, 20% are facilities like here in the academic setting. And the majority of oncologists in the general community are generalists. They see a variety of cancers each and every day. And our research question was really whether there is an association between the experience of delivering care for a specific subtype of cancer and those subsequent clinical outcomes. And so we initially focused on my own clinical specialty, which is lymphoma. And we focused on diffuse large B-cell lymphoma, which is the most common of the lymphomas. Its median age is about 70. And so our group has access to Medicare claims data. And so we typically like to study diseases that are of the aging. And it's highly aggressive. If it's untreated, diffuse large B-cell lymphoma will lead to mortality within weeks. But it's actually highly curable with immunochemotherapy. And so consensus guidelines recommend immunochemotherapy for diffuse large B-cell lymphoma regardless of age, but there are certainly concerns, and I think just concerns over treatment toxicity, and that actually limits administration in the older population. And so our hypothesis going to this study was that patients managed by oncologists with greater experience by doctors treating older individuals with lymphoma would be associated with greater treatment selection and overall survival. And so for this analysis, we use SEER Medicare. SEER is a group of cancer registries that come together, including Connecticut, which capture clinical demographic as well as survival information on incident cancers in these regions. We can then link that cancer registry data to comprehensive Medicare claims, and effectively you cover about 25% of the entire Medicare population in the United States. And so with that data, we conducted a population-based cohort study of patients greater than 66 years of age that were newly diagnosed with lymphoma over about 10 years. The primary outcomes of our analysis were threefold. One was treatment selection. Did a patient that had a new incident case of diffuse large B-cell lymphoma receive chemotherapy? And if they did, was it guideline recommended? Was an anthracycline curative intent treatment? We then looked at early hospitalization rates, looking at 30-day after chemotherapy initiation, and then finally overall lymphoma-specific survival. So if you look at the surgical literature, most of the volume outcome studies use an aggregate volume. Instead of this kind of more aggregate or average, we tried to be a little bit more refined in our volume. And so what we did is we actually looked at the number of lymphoma treatment initiations and Medicare claims that a provider had within the last 12 months of each incident DLBCL case. So it's a rolling volume measure. And we borrowed from the surgical literature of this idea of doing tertile. So we had a low, medium, and high volume provider characterization. So in this analysis, we identified about 8,200 Medicare beneficiaries that were newly diagnosed with diffuse large B-cell lymphoma, and they received their care from about 2,500 oncologists within SEER Medicare. These oncologists initiated treatment on a total of about 25,000 Medicare beneficiaries with lymphoma, so that's diffuse large B-cell lymphoma, among other histologies. And the median number in the last 12 months for these providers was 2, with a range of 0 to 30. And here are the outcomes. So about 75% of patients that are newly diagnosed with diffuse large B-cell lymphoma receive at least a cytotoxic chemotherapy, and you had a greater odds of receiving chemotherapy as you went to a higher volume provider. So low, medium, high, this was kind of a dose-dependent association. And these are multi-level logistic regression analyses that have covariates, including things like age, sex, race, comorbidity, disability status, among others. So pretty robust adjustment in these models. So that's receipt of chemotherapy. And those patients that receive chemo, was that chemo with curative intent? Was it a guideline recommended therapy? And you see here that 71% of patients received a guideline recommended regimen. And again, it was more likely that you would see a guideline recommended if you saw a provider with greater experience treating lymphoma patients in older adults. And then lastly, hospitalization occurred in about 26% of patients that were newly initiated on therapy. And the odds for hospitalization were lowest in those patients that were treated by the highest volume providers. So at the end of the day, higher oncologist volume was associated with the receipt of chemotherapy, greater odds of receiving a treatment with curative intent, and then having lower odds of hospitalization. This is our survival analysis. And so on unadjusted analysis, you see here, there is some separation of the curves with the highest volume providers, those patients having the greatest survival. When we do multivariable Cox regression analysis, there was about a 15% reduction in the risk of death if you receive care by the highest tertile of a lymphoma provider. If we look at the subgroup of patients that are receiving guideline recommended therapy, the volume survival association goes away. And so our thought is that the volume of hospitalization as well as the volume survival is really in part due to greater selection of the appropriate chemotherapy, a greater understanding of toxicities perhaps, as well as intensification. And so this is what we find here, that volume outcome basically goes away. So that's diffuse large B-cell lymphoma. We next wanted to look at whether volume outcome association is persistent, looking at a specific treatment. So as a provider gets more experience giving a certain treatment, are those outcomes of that treatment better? And so for that, we looked at Rituximab. So why look at Rituximab? This is the first approved monoclonal antibody that was approved in 1997. It binds CD20 on B lymphocytes, and in randomized trials, it's improved survival across many B-cell lymphoma subtypes. While it's really well tolerated, there's a relatively unique side effect of an infusion-related reaction, which is quite common. So patients experience infusion-related reactions during the first or second dose. If they tolerate the first or second dose, they typically do very well with this treatment. And while most reactions are manageable with things like Benadryl and steroids, there are a few life-threatening events that can perhaps increase the concerns of providers without as much experience. So we use a similar population-based cohort study that used SEER Medicare to assess outcomes in these patients initiating rituximab. We hypothesized providers with infrequent use of rituximab may be less familiar managing the side effects, and thereby patients seeing these lower volume providers would be more likely to discontinue treatment, receiving just 1 or 2 doses. And so here we have the primary outcome, early discontinuation of this drug, defined as less than 3 doses of rituximab within 180 days of initiation. Typically, rituximab is given for 4 to 6 doses over the first 6 months. And our primary predictor value was very similar to the previous. We had a 12-month look back, but instead of counting lymphoma cases, we counted how many times a provider had initiated rituximab in Medicare. Again, we used a low, medium, high volume. And so this wasn't just diffuse large B-cell lymphoma, this was all B-cell non-Hodgkin lymphoma, so it's a larger population. We had about 18,500 patients, and we linked them to a very similar group of oncologists, 2,600, almost 2,700 providers. We limited our analysis to those that were alive for 180 days so they could be exposed for the 180 days, which was in our outcome. So we find 7.6% of patients actually discontinued rituximab, which is higher than we see in clinical trials. Usually it's about 1 to 3%. Again, this is an older population. There's certainly competing risk here, but this was a pretty significant increase that we weren't entirely expecting. We also find here that provider level volume or experience giving the rituximab is associated with risk of early discontinuation. Again, this is dose dependent, where we have the highest volume providers, those patients treated by them are less likely to discontinue treatment. And if you go to the lowest volume, you have the greatest risk. So compared to patients treated by physicians with greater than 3 rituximab initiations in the last year, those treated by the providers without any were 57% more likely to discontinue rituximab. So we next looked at discontinuation survival. So we have randomized data to show that rituximab improves survival, and you have to get rituximab to benefit from it. So those patients that had early discontinuations did poorly. You can see here a separation of the curves. And these findings were consistent on both a 12-month landmark analysis as well as a sensitivity analysis, where we only looked at dropping the rituximab. So patients were on R chemo, they stopped the R, continued on chemo, and in those situations, outcomes were again inferior. So the summary of these 2 studies is really similar to complex healthcare settings of surgery. We find oncologists' experience or volume is associated with important outcomes in 2 lymphoma settings. The first being diffuse large B-cell lymphoma, where we find greater oncologist experience treating older adults is associated with receipt of guideline recommended chemo, lower hospitalization, and ultimately survival. And then in rituximab, we actually find greater experience using the drug associated with lower risk of treatment discontinuation. So how do we improve upon cancer delivery by addressing this volume outcome relationship? For complex surgeries where technical skills and processes of care may not be readily transferable, I would argue that perhaps centralization is actually quite important in doing so. Not the case for medical oncology and really medicine in general, where I would expect that clinical experience and knowledge is much more readily transferable. But I would argue that the current approach that we generate and disseminate knowledge is really outdated. We live in a fast-paced, cloud-based world, and we should be able to generate and disseminate knowledge better. So our post-approval world is really data-rich or data-poor or opinion-rich, where we have randomized control evidence that really is quite narrow. We have an average effect size. We have a trial population that doesn't represent the general population. We often lack comparative effectiveness between 2 suitable treatment options. And then many of our day-to-day clinical decisions are not informed by high-quality evidence. These are including things like drug-related toxicity management in oncology. So what might the path forward? So if you read JAMA New England Journal, every month we see new kind of viewpoints on moving towards a rapid learning healthcare system using big data. This is one such kind of schema where we have a wealth of information in this digital knowledge area, patient demographic, personal clinical data. If you put that in a computer, you have machine learning, AI, you're synthesizing and finding new associations, and then having that go back to the clinician to help make decisions. And this is an iterative process. So what potential insights might big data derive for us in our settings that we presented earlier, diffuse large B-cell lymphoma, rituximab? It's likely that higher volume providers reduce the dose of chemotherapy for that first cycle and then escalate treatment. That's a fairly nuanced thing that I think high volume providers do. We might actually derive that from this big data. Similarly, rituximab often will have a high dose therapy would split the dose over 2 to 3 days, escalating dose and kind of improving management and tolerance of the therapy. So these are the type of insights that we might actually derive from looking at clinical data. However, machine learning does not overcome the inability of observational data to really produce causal inferences. And so it will be important moving forward to not only have big data, but also point of care trials, randomization in the clinic embedded within our EHR. And so for low risk clinical scenarios, I see associations that are identified using AI and machine learning to be quite sufficient to inform clinical decisions in these support tools. But for most other clinical scenarios, we still will benefit from randomized trials. The hope is that we have pragmatic trials that are really embedded within our smart EHR systems that generate evidence to inform common unanswered clinical questions. So this is kind of a big picture. What does this actually look? How do we go from this to implementation? And that's what this pilot study will do. So we'll talk about ibrutinib, which is a oral administered tyrosine kinase inhibitor that targets the bruton tyrosine kinase pathway. It is incredibly effective in CLL. It's a drug that's taken continuously, and it's taken until either disease progresses or patients have major AEs. In clinical trials, drug is well tolerated. It really is quite efficacious. This is the ibrutinib versus chlorambucil, and you can see here 84% reduction in the hazard of progression. However, the drug has toxicities, and so these toxicities are very dissimilar from traditional cytotoxic chemo, and include things like arthralgias, which can be difficult to manage, GI disturbance, bleeding, and AFib. Those are the common that lead to discontinuation. And while these toxicities are generally limited and manageable, clinical trial rates of discontinuation due to AEs were quite low, about 5%. When you look at the real world, about 40% of patients are discontinuing ibrutinib due to adverse events. So that's leading to the median duration of therapy of less than 18 months compared to clinical trials where patients are on therapy for 3, 4, 5, 6, 7+ years. So to try to address this, we're partnering with Flatiron Health. Flatiron Health is a real-world evidence platform with data on over 2 million cancer patients in the United States. Most of this data is really derived from Flatiron's EHR system, which is called OncoEHR, and that system is effectively used in about 200 community oncology practices. We've looked at the data, and we have about 5,000 patients in Flatiron that have been prescribed ibrutinib between 2016 and 2019. And the hope is that we can really look at that data to try to identify patterns of care that are associated with improved outcomes. And so our hypothesis here is that patients that are treated by either CLL specialists or those providers with greatest experience using ibrutinib will experience less discontinuation, and we'll be able to find some patterns of supportive care that are associated with experience as well as discontinuation. Ultimately, we aim kind of more broadly to develop and refine an approach that critically evaluates cancer care using large road data, identifies common management strategies for scenarios lacking high quality evidence, and then it generates an EHR embedded clinical decision tool that disseminates best practices to providers. And then if there isn't a best practice that's available, it actually tests directly these interventions using point of care randomization. So again, what would this look like? It's really a hybrid clinical decision support tool and EHR that embedded trial kind of within one. So this is how we envision it, that if a patient or provider rather was going to start a treatment, you would actually get some insight of what other high quality, high volume providers are doing. And so it says you are initiating ibrutinib, CLL specialists with the experience using ibrutinib obtain routine blood work and see patients frequently during the first 3 months to identify and manage adverse events. Would you like to schedule similar follow-up to these high volume providers? And again, you can say yes, you could say no. We certainly want physician autonomy, but you would be able to kind of derive what is the common way that these providers are following their patients and do just that in the community. If you have a patient that comes in with a toxicity, you would perhaps try to change the dose, and there would be prompted to say, hey, why are you ordering this dose reduction? Can we get some information about your symptoms? And then the next step really would be to help manage those symptoms. So this patient came in with myalgias. You'd select that. And the management in a scenario of myalgias is really lacking high quality evidence. So we don't know how best to manage this. And so what this approach would do is it would look at the real world data. It would see what are the most common ways that current oncologists are managing this, and it would allow randomization to that. So in this situation, you would basically be able to ask a patient to undergo randomization to the two most commonly employed strategies. Here, strategy A would be to stop ibrutinib and then resume once the symptoms subside. And strategy B, which is something I commonly do and among other CLL specialists do, is we actually initiate a prednisone taper to see if that works. Again, you could say no, a patient could say no, but this would allow us to effectively rapidly answer these questions with high quality data. Furthermore, if a patient agreed to randomization, this kind of prompt would effectively prescribe the treatment. And again, this would actually be informed by the real world data that we're deriving in our large data sets. So in conclusion, similar to complex surgical settings, provider level volume is associated with important clinical outcomes in older patients with lymphoma. The hope is that by combining big data analytics and point of care randomized trials, rapid learning healthcare systems, as well as these smart EHRs, will really be able to enable delivery of high quality modern care. How do we do that? We efficiently generate evidence that addresses unanswered questions. We rapidly disseminate this knowledge back to practicing clinicians, and ultimately this will support delivery of complex care in both academic specialty practices as well as community oncology. So for this, I want to thank Yale Copper Group, as well as some academic CLL partners that are working on this ibrutinib project. And really, this is for community-based oncologists, right? So we're trying to derive a tool that would be helpful. And so we're really trying to find some community partners to engage with. And then finally, Flatiron, as well as the funding for this, which was YCC pilot, as well as the KL2. I'd be happy to take any questions.
Yeah, so we have time for plenty of questions.
Thank you for that. I was wondering, physicians. Yeah, so wondering, physicians then have a lot of notifications on their electronic health records already. Every time they open it, there's already a couple notifications for other meds need to be renewed or follow-up appointments that need to be made. So how do you stop them from becoming null to these constant, pop-ups to would you like to follow this recommended course? Because I feel like a lot of physicians already ignore the existing notifications that they get.
Yeah, it's a good question. So effectively, you have to have these prompts be helpful, right? So this development would only occur if we get buy-in from the community oncologist. So this is a tool that would be helpful, perhaps we need to rework, or we definitely do need to rework our current EHR to really provide these prompts that are helpful, that really augment our intelligence when treating patients on a day-to-day basis. So I don't see our current EHR systems being able to deliver this. There's just too much noise, but certainly a more refined, streamlined EHR perhaps would in the future.
Yeah, I guess along the same lines, one message from all this is that some of these outcomes are not connected to the size of the group, which is a structural issue that's probably difficult to change across the country, but rather an information dissemination and acceptance issue. And I'm wondering, outside of this fairly sophisticated and tech-heavy approach, is there low-hanging fruit in terms of better communication and engagement by the community programs?
Yeah, I would argue that Smilo is one of the best situated groups, right? So we have academic and care centers that are really well integrated, much better than many other places in the country. So we are doing that in terms of having tumor boards that are inviting community oncologists to call in. So I think this is actually a really great system to start developing and testing, piloting some of these approaches, because I don't think that it's likely that rural oncologists will be able to super specialize, right? I think general oncologists will still need to be there, but we are having just an information tsunami that needs to be parsed and delivered better so that these oncologists can make the most informed decisions for their patients. And that's, I do think tech and kind of smart EHRs are probably the way forward.
And as you mentioned, we are a bit of an outlier in being a tightly integrated and geographically condensed system. But what about more rural areas, places away from academic centers?
Yeah. So the OncoEHR is used in community centers throughout the country, including rural. Yale, UAB, UPenn actually give data. So the idea behind that is, could we use this big data that includes some high volume specialists and actually disseminate those knowledge, that understanding, to rural oncologists in Montana that are using the OncoEHR? Absolutely. So that the idea is that we're one large community, and Yale is relatively small, but OncoEHR and Flatiron really sees itself as kind of a national platform, and perhaps that may be the vision of the future.